Welcome to the McTox Curriculum, brought to you in collaboration with Western University, the University of British Columbia, and McMaster University. This presentation is part of McTox Curriculum built for residents and fellows from PGY 1 to 5. Today we will cover beta blockers and calcium channel blockers. Our module will discuss the physiology of a beta blocker and calcium channel blocker overdose and how it pertains to the resuscitation and management of these cases. Given our theme of antidotes, we will touch on specific treatments that can be used and our current evidence for what should be used in practice. Remember throughout this module that most beta blockers and calcium channel blockers present similarly and that their management will intersect at a number of points. The first important concept to learn is the classification of calcium channel blockers based on their underlying chemical structure and targeted effects. As you can see, there are 3 different categories, but what we actually care about clinically is the difference between the dihydropyridines and the non-dihydropyridines. Non-dihydropyridines, which are verapamil and diltiazem, act on both the heart and the blood vessels. Dihydropyridines, on the other hand, act primarily on the blood vessels alone. In the case of a large overdose, however, this selectivity may disappear, and you will have a combination of effects. Going on to our first case. You have a 59-year-old man who comes to the ED, awake and talking, after taking an overdose of his diltiazem at home approximately 2 hours ago. He says he took 30 tablets, each 300 milligrams, and denies any co-ingestions. All of his vital signs are within normal limits, and his physical exam is unremarkable. You start his workup and leave to see a few other patients, and are called back to his room stat by his nurse because his pressure has been trending down and is now 80 on 44. His heart rate has also dropped to the low 50s. You are unsurprised at his change in vitals, given your understanding of the calcium channel blocker mechanism of action. As the name suggests, these medications block the influx of calcium into the cell. This results in vasodilation, decreased cardiac contractility, and decreased conduction to the SA and AV nodes. Clinically, this translates into hypotension and bradycardia, or the slow and low toxidrome. Our second case is a 77-year-old man admitted to medicine in your department with uncontrolled AFib. You've been called to assess him as he looks quite unwell and has concerning vital signs. You quickly look through his chart and see that he was accidentally given 50 milligrams of IV metoprolol instead of the usual 5. Beta blockers like metoprolol block the activity of beta-1 and beta-2 adrenergic receptors. Beta blockers have a variety of types ranging from selective to non-selective. However, in an overdose setting, they often lose any selectivity. The main clinical features are hypotension and bradycardia, but you can also have hypothermia, hypoglycemia, and many other dysrhythmias. Clinically unique beta blockers are propranolol and labetalol. Propranolol, which in addition to its beta blocker activity, also acts as a sodium channel blocker and is lipophilic, which means it can easily cross the blood-brain barrier and cause seizures and an altered LOC. It's a very bad drug to have to treat in an overdose situation. Labetalol is also special because it has both alpha and beta blocking effects, which can result in a greater degree of hypotension. Let's move on to our management options. The first step treatment for both beta blocker and calcium channel blocker overdose starts with supportive therapy of IV fluids and pressors to correct for hypotension. You can use conventional antidotes for the bradycardic and hypotensive patient, knowing that they will likely have limited clinical effects, such as giving calcium in a calcium channel blocker overdose or glucagon in a beta blocker overdose. Atropine is also included in this step and is reasonable to use if the cause of the symptomatic bradycardia is still unknown. What's actually going to improve the patient's clinical picture and shock are the more advanced antidotes, such as high-dose insulin, lipid emulsion therapy, and methylene blue. These advanced antidotes are going to be discussed in detail in the cutting-edge antidote theme in the advanced module section. However, we'll talk about them briefly here. Hyperinsulinemia euglycemia therapy is the administration of a high-dose IV insulin at a much higher rate than is used in DKA treatment. These infusions can be started at a dose of 0.5 units per kilo per hour and increased up to 10 units per kilo per hour, Some cases report uses up to 22. Obviously, the treating physician should closely monitor the electrolytes and blood sugar, given the risk of hypoglycemia and hypokalemia. Intravenous lipid emulsion therapy is just what it sounds like. An infusion of a solution with a high fat content, about 20%, which is actually quite similar to TPN. An easy, practical dosing of lipid emulsion therapy starts with grabbing a 500 ml bag of intralipid and giving a 100 ml bolus over 1 minute, and then the remaining 400 ml infused over 30 minutes. This will give you the recommended 1.5 ml per kilo in the first minute and 0.25 ml per kilo for the infusion for the average 70 kilo patient. The bolus of 100 ml can be repeated if needed, but the total dose shouldn't exceed 10 ml per kilo. In our last antidote, methylene blue has shown some benefit in cases of distributive shock, the similar picture that's caused by a calcium channel blocker overdose. It can be given as a 2 ml per kilo IV bolus, which can then be repeated once if needed. It's important to remember that it's contraindicated in patients with renal failure and G6PD deficiency and has some serious side effects, including dysrhythmias, hypertension, headache, and hemolysis. The majority of the calcium channel blocker and beta blocker overdoses that we see are in young, relatively healthy patients. If we can support their vital signs and maintain an adequate cardiac output throughout their overdose, there's a very high likelihood that they'll return to their full neurologic function. Sometimes, despite all the antidote treatment, we need to use more invasive life support measures to achieve this. Some of these advanced life support options include an intra-aortic balloon pump, left ventricular assist device, ECMO, or emergency cardiopulmonary bypass. Their availability for use would depend on your hospital and be used in conjunction with cardiology or cardiac surgery. In terms of enhanced elimination, most beta blockers and calcium channel blockers aren't dialyzable, but a few of them will be removed by hemodialysis. The most common from this list include atenolol and sotalol. Some of the therapies we mentioned in this module are part of the general supportive care of a sick patient and don't need to be supported by a high level of evidence, such as giving IV fluids to a hypotensive patient. Other antidote medications make sense to give based on the physiology of the drug, like glucagon for beta blockers and calcium for calcium channel blockers. Most of the other advanced or invasive treatments have some degree of supporting evidence in the literature that consists mostly of case reports, case series, and lit reviews. Those include high-dose insulin therapy, lipid emulsion therapy, methylene blue, and invasive life support. Finally, we're at the end of our module, and there's 3 questions to be completed for the take-up session. Question 1. List 4 dialyzable beta blockers. Question 2. What's the underlying pharmacologic theory to use glucagon in a beta blocker overdose? And 3. Looking at the treatment algorithms for both beta blockers and calcium channel blockers, what's the step that's unique to treating a calcium channel blocker overdose? And that's it. Thanks for watching.